Assalamu alaikum. Thank you for invitation دكتور محمد وهمين. المحاضرة بتاعتنا النهارده هنتكلم عن ال current role of PET-CT in lung cancer. Lung cancer is a leading cause of death of cancer-related deaths worldwide. Non-small lung cancer represents about 80% of cases with subtypes, including adeno, squamous, and large cell carcinoma. The histological subtype, molecular features, and tumor stage all affect how non-small cell lung cancer should be managed. For screening of lung cancer, low-dose CT is the usually used method for screening. It reduces lung cancer-related mortality by 20%. However, 96% of nodules detected on low-dose CT are benign. To date, there is no universally accepted clinical pathway for evaluation of nodules detected incidentally on low-dose CT during screening. Routine FDG PET-CT for every lung nodule adds significantly to the cost of care. However, PET-CT may be used for selective screening of high-risk population with a good sensitivity and specificity. These are two examples of nodules detected on low-dose CT, PET-CT. One of them showed low metabolic activity, and the other shows high metabolic activity. It should be considered that FDG has lower specificity in regions with endemic lung infectious diseases compared to non-endemic areas. The next step after detecting nodules on PET-CT, radiological follow-up is recommended for all lung nodules interpreted as benign on FDG PET-CT. A biopsy is recommended for malignant or indeterminate nodule with reported sensitivity and specificity of 94 and 82%. Other incidental findings on FDG PET-CT are very common and should be trigger further workup. For staging of lung cancer, the optimal imaging technique should assess the primary tumor, the metastatic nodal lesions, and also distant metastasis. In non-small cell lung cancer, the expression of both hexokinase activity and glucose transporter proteins are upregulated. This leads to increased uptake of fluorine-18 FDG. The National Comprehensive Cancer Network guidelines recommend FDG PET-CT for the evaluation of patients with non-small cell cancer in all stages. FDG PET-CT for staging of patients also made reference in the American College of Radiology appropriate criteria and American College of Chest Physician guidelines. For staging FDG PET-CT result in 51% relative reduction in futile thoracotomy with overall 1 in 5 reduction in unnecessary surgery compared to conventional workup. This is an example of one of our patients with right upper lobe lung cancer, and the PET-CT detected another hypermetabolic nodule on the same lobe, leading to upstaging of the patient to T3 stage. FDG PET-CT may also help in guiding transthoracic biopsy by localizing most viable portion of the lesion and thus increasing the rate of accurate diagnosis. This is also one of our patients with a mass having central necrosis. Numerous studies have compared FDG PET-CT and for lymph node staging in non-small lung cancer, demonstrating its superiority in small-sized or normal-sized lymph nodes compared to CT. This is one of our patients with multiple sub-centimetric nodules in the mediastinum detected on FDG PET-CT. a better performance of dual time point PET-CT compared to single time point for mediastinal staging. This is one patient imaged at 60 minutes and 120 minutes with the uptake in the mediastinal lymph node increased in the later images. One of the most important tools for whole body PET-CT is its whole body imaging detecting distant metastasis, combining density measurements and house field units on contrast enhanced CT, and SUV's threshold PET-CT proved to be more specific than PET-CT or CT alone in the detection or characterization of adrenal metastasis. PET-CT is superior also to bone scintigraphy in detection of osseous metastasis as the lesions are mostly osteolytic. FDG has limited sensitivity in detecting brain metastasis due to its high glucose uptake in the brain tissue. MRI remains the method of choice for staging the brain, although there are patients with accidentally detected brain hypermetabolic lesion confirmed to be metastatic. Temporoparietal lobe hypermetabolic lesion detected on PET-CT along with other multiple metastatic lesions involving even soft tissue and muscular metastasis. More than just the detection of lesions, the metabolic activity of the lesion affecting the prognosis in lung cancer. The total body tumor burden is a measure of the overall burden of cancer has been shown to be strong correlation with prognosis and survival for non-small cell lung cancer. This is one of our latest papers concluded that whole body tumor burden in terms of total metabolic tumor volume and total lesional glycolysis are more correlated with overall survival than other clinical assessment of the tumor itself. For treatment response assessment, it allows for differentiation between fibrosis and necrosis and residual or recurrent tumor after surgery or radiotherapy with higher sensitivity than other modalities. Yet, optimal time of interval after radiotherapy or surgery minimize false positive results due to inflammatory changes. The most optimum time of imaging after surgery ranges from 8 to 12 weeks after end of therapy. Other tracers than fluorine 18 FDG are also used for the imaging of non-small cell lung cancer, including fluorine 18 fluorothymidine, FLT. It's a biomarker of cellular proliferation. It has higher specificity than fluorine 18 FDG, yet it has lower sensitivity. It's got predictive value for assessing response after radio or chemotherapy, especially after targeted therapies. It assesses early response. Although it cannot replace FDG in detecting small and early lung cancer, it may help prevent patients with larger or inflammatory lesions from cancer misdiagnosis or over-treatment. This is one patient who has T3 and 0M0 large cell carcinoma. The first images show the tumor, and the second images after 2 weeks of initiation of chemotherapy shows tumor progression. So there was change of the therapy, and the last images showed response. For small cell lung cancer, it is an aggressive, high-grade neuroendocrine tumor characterized by rapid growth and early development of metastasis. Compared to non-small cell lung cancer, fewer data are available about the impact of PET-CT on staging of these patients. It has 2 stages, limited stage disease confined to ipsilateral hemisthorax, and extensive stage disease spread beyond the ipsilateral hemisthorax, which receives just palliative therapy alone. Current NCC guidelines recommend the use of FDG PET-CT in patients with suspicious limited stage disease being considered for treatment with curative intent with change in the staging up to 15%, either by upstaging or down staging. Thank you.